Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. Hi, everybody. This is another fun time with Own Your Heart Health with Dr. Regina Druz. And I'm super excited today because I don't know if you remember, but some time ago, I had this little short video and I was talking about biohackers and bioslackers, right? So today in my studio, I have a phenomenal guest. It's Dr. Jeffrey Gross. And Dr. Gross is a self-described Bionerd, his words, not mine. And, you can use Bionerd or you can use a biohacker, whatever you feel is the most appropriate designation. But I'm so happy to see that Dr. Jeff Gross is another traditional recovering physician who had actually managed to early on, approximately 7 or 8 years ago, maybe a little bit longer, pivot his practice into more longevity-driven regenerative medicine. And with longevity being the buzzword these days and, the influencer culture sort of feeding us their interpretation of longevity, I'm super excited to have Jeff here because he actually represents what longevity is, right? A dedicated practitioner who studies the physiology, the biochemistry, and understands how to connect the dots so that we can bring this knowledge to you as well. So, Jeff, I'm going to ask you a question. I ask all of my guests, it's a universal question. How did you grow up to be who you are today? Give our audience some flavor, please.
Wow. Well, the short version is, and thank you for having me, of course. It's great to talk to you and your listeners. I was practicing traditional medicine, and I'm a neurosurgeon. I'm a spine fellowship trained doctor, a lot of neck and back patients, disc problems, et cetera. And we were always looking for ways not to do surgery, less invasive, more natural biologic ways. And I sort of didn't fit in with the rest of my colleagues somewhat. They would go to the annual meetings and hear the same things and do the same things. Spine surgery hasn't, appreciably changed in decades. So, I felt that we were, not moving forward. So I finally put down the Kool-Aid fully. And I said, I want to add stem cells. My patients were clamoring for stem cells. Hey, we heard about stem cells. It sounds cool. What do you got? And I didn't have anything. I said, but my background's in biochemistry. I just haven't been able to do much. And you were right, Dr. Regina. You said, at the core of all these things, it's cellular function and biochemistry. It's what's going on, and so that really kind of resonated back full circle to my education. And I went to study stem cells and things related to stem cells, and it just blossomed and caused me to flip my entire practice into a 2.0 version. And that's all we do now is stem cells, exosomes, peptides, regenerative applications, longevity, cutting edge. I'm more functional in a mindset than I've ever been. And I love it because it just enhances what I learned in my medical degree, but now I can apply it better and fewer pharmaceuticals, less surgery.
And so how did your traditional, medical colleagues react? I'm asking this because, I'm a cardiologist. I'm still a board certified cardiologist, and I will be, for as long as I remain to practice. Yeah. And my goal was the same as yours, to bring these innovations into the field of cardiology. And what's been interesting is that we had sort of seen traditional cardiology move step by step by step. And now it's sort of accelerating into this more integrative domain, like our Journal of American College of Cardiology just published a huge research paper on using a, Chinese movement technique. I think it's called Banjun, and how I'm probably butchering this word and how it helps people to control their high blood pressure. And then, we have all these articles on microplastics and particulate matter. And, I'm looking at this and I'm like, hey, this is all integrative cardiology stuff, but how did your conventional colleagues, sort of regarded you once you branched out in this new 2.0, practice model?
Well, a lot of them still have the blinders on and say, what are you doing? Why aren't you doing more surgery? It's all about the volume. We have to do the volume. And these are the people that I call it the tail wagging the dog. They are doing what the insurance company wants them to do. They are doing the things that they can get approved by the insurers who are really driving, healthcare decisions. So there's just a kind of a dumb cog in the wheel sometimes. A few of my colleagues are like, what are you doing over there? Let's talk about that. I have a very few open-minded, very good people who, hey, I might be able to apply some of that. They're ready to dip a toe into it, But they're holding on safely, to that, sick care system because it pays their bills, right?
It pays the bills, right? So that security blanket of a healthcare system. But you and I in the field of longevity do know better, right? And hopefully, the future favors the bold, and not all pioneers get arrows in their back. So far we've been trying to escape at least some of them. So what do you feel, based on your experience? First of all, I want our listeners, I want myself to understand, what are stem cells? How are you using them? What are exosomes? How you're using them? And what do you think? Do you feel that, there's a lot of questions and we'll unpack all of them, but do you feel that those interventions, right? Because they're all interventions, are those interventions, what is their impact on longevity? Is it sort of the impact in a specific area, or is it more of an impact that, transcends several areas and sort of repositions a person appropriately into a better what we call health span curve, right? Does it square off that health span curve? So I'm super excited to learn about this.
Well, it depends on the application. So let's do a little stem cell 101 for everyone. But when you are a fertilized egg in your mother's womb, you are a single omnipotent stem cell. You can create a person. You're very powerful. Those cells, divide into an embryo. First of all, it's a ball of cells, and they flatten out, as you remember from med school, and they have layers like a sandwich. Then we start to curve into a lizard-looking like thing, and then finally we look like a baby, right? And those cells go from omnipotent stem cells into pluripotent stem cells. They're not as powerful as they develop, but they can create a limb or an organ. They're still incredible. And then those cells, eventually when you're born, are no longer pluripotent. They are multipotent. They can do a lot. They can replace tissue. They can help you heal and grow and develop, but they're not going to create a limb. Now we're learning how to do that. That's the topic for another day. So we're born with all these multipotent stem cells. And as we grow and develop, we're using them. When we're adults, we call upon them, but with age and exposure to the world of inflammatory stresses, and we all know that comes from diet, lack of exercise, seed oils, poor sleep. We could make a long list of all those things. Those cells don't function as well. They become exhausted. They become fewer in number and fewer in function, or lesser in function.
So Jeff, just a minute. So where did those now sort of grandbabies of the original stem cells, right? Because it sort of goes through these generations. Where do those grandbabies of the original stem cells actually reside in the adult body? Like, do we have a little bit in each organ, or do we have sort of like a depot that, potential one can tap into?
Most are in our bone marrow. Many are in our fat and other tissues and other organs surrounded around the vessels. So we can call upon them. They're in all of our tissues to some extent. And so you asked, that's stem cells. And when we use stem cells therapeutically, you can use them from your own body. But Dr. Regina, when you take your car to get the oil changed, you don't put the old oil back in. So I love the donated perinatal sources. This comes from amniotic fluid, umbilical cords, and placenta. At the time of a C-section birth of a healthy screen, consenting, ethically sourced mother who's like, take this stuff. We were going to throw it away anyway, right? And that's where we get a lot of our stuff. It goes through an FDA-registered lab process. It goes through tissue donation, registered, approved processes. This is not unethical. You do not need to leave the country. Those are myths that the international clinics love to perpetuate. We have them here in the States. and they are highly tested. In fact, the source that we use for our biologics, I'll use that word because it represents stem cells, exosomes, and other things we'll get into shortly. Our source uses only non-COVID vaccinated mothers because we don't want that variable. We don't know enough about what that spike protein is doing yet. I mean, we're learning some things, and some of it we don't like. So we want to remove that variable, and we are having some really cool results.
So this is fascinating because I'm sure, your practice, my practice, we're sort of following the FDA peptide roller coaster, right? So which is in full effect, and the whole sort of what I call negative externality that the FDA created by pushing some of the peptides into so-called category 2. So it created this whole gray market of peptides, which are basically unregulated, unvetted, nobody knows where they're coming from. Maybe they're coming from overseas. People are using them without any discretion, potentially running into serious issues. So, but here with stem cells, you're saying that there is an FDA regulated pathway. So how does that FDA regulated pathway actually work?
Yeah. And I could speak to all your comments on peptides because I think there's a lot of mythology that we need to, cure. But, with regards to biologics, whether they're stem cells, exosomes, and even peptides, these are all biologic signaling of some form. Cells respond and change their behavior from bad to good is the goal, right? We can do it the other way, but we're already doing that with our lifestyle. So the process is FDA regulated. We as clinicians and suppliers as manufacturers, even though they're not manufacturing anything, they're just testing it and making it available. We cannot make any claims, marketing claims, because remember, everyone listening, the FDA does not regulate the practice of medicine. The FDA regulates safety and efficacy claims, marketing claims, and you can look this up. Now, you hear this phrase, FDA approved. And people freak out if it's not approved. Most of what we do as clinicians is not approved. IV fluids for dehydration is not FDA approved, but everybody does it.
Exactly.
So let's be frank. A clinician can safely do what is best for a patient under the doctrine of informed consent, where we go over all the options. And so if you're looking at a knee replacement and your doctor does not give you an option to try some type of stem cell or regenerative exosome procedure, that doctor has failed the informed consent doctrine. So you have to know all the options. You have to have a doctor help you learn about the pros and cons, the risks and benefits, so that you, the patient, can make the most informed and best decision for yourself. And that's very important. And that's the underlying process. The FDA does not regulate that at all. So a doctor can do what's best for a patient as long as the patient understands it, the patient agrees to it. And we as doctors don't make any claims. Now, as a surgeon, I've never made any claims. We can't guarantee anything. And as a heart specialist, you've probably never
made cannot guarantee anything either.
This beta blocker is going to fix your dysrhythmia, right? We can try it, right? Medicine is trial and error. That's why they call it a practice, right? So why not expand what we can try? And now there are some right to try laws. They're worded funny, but that's for a different day. So the FDA regulates the process of handling these things, the documentation of these things, and the marketing claims. They do not regulate the practice of medicine. We can do what's best for someone if they want to try that option. So if you have, osteoarthritis of your knee and you want to avoid that joint replacement, you want to try something, a single injection, there is an option for you. I'm not the only clinic that can do it. There are plenty of clinics in the US.
Interesting. So what have you seen using those embryonic stem cells, right? Am I labeling them?
Any embryonic stem cells. Embryonic means coming from the embryo. We don't borrow from the embryo. We call them perinatal, around the time of birth. This is stuff you throw away traditionally. And some cultures, they eat the placenta. You can, right? So they know there's something very healthy in the placenta.
Interesting. So those perinatal stem cells, they get, I'm assuming, harvested, tested, purified, and whatnot. And so a physician such as yourself uses them to alleviate certain health conditions, right? I'm not going to say treat because, as you said, we can make certain claims, but sometimes these claims fall short. So give us sort of an understanding. What are the health conditions that you find are potentially influenced or helped, positively by stem cells? What kind of efficacy they have,
Right.
and how does that relate to longevity? And by longevity, I always look at a much sort of broader umbrella, right? Not just health span and lifespan, but even functional optimization, right? Which could technically be a subset of a person's health span, right? Improved mobility, vitality, things like that. So what does that look like?
You're so right. Well, first, we've discovered, not me personally, but published that the stem cells really aren't doing the job. So if you came to my clinic here in Las Vegas and you said, "Hey, Jeff, I'd love to try some IV intravenous stem cells. I need a boost. Let's try that out." You would come in here, we would do it, and then I would tell you in a couple of days, those stem cells are gone. And you'd be like, "Wait a minute, I just paid you good money for those stem cells. I want them lasting." I'd say, "Well, hold on, Regina. The benefits of those stem cells, the signaling to your cells lasts weeks and months, and some of those changes are permanent." And you say, "Wait a minute, but the cells are gone. What's imparting that signal?" The answer is the stem cells deliver. They are the delivery trucks, the Amazon trucks. But the actual packages come in peptides, growth factors, and vesicles, extracellular vesicles that we call exosomes. Those exosomes are highly deliverable to our cells. The cells take in the cargo, and it signals to our cells to stop being inflamed and make anti-inflammatory pathways more accessible. Produce anti-inflammatory cytokines. That's a big word, meaning peptides and growth factors. Influence the neighbor cells. That's what's going on. That's what turns back on your youthful cellular restorative apparatus for healing, for longevity, for cellular function. All those things you mentioned. That's how you do it. You can do that with peptides. You can do it with stem cells. You can, if you want to save some money and be more bioavailable, you go right to the exosomes. That's what we're doing now. We're skipping the stem cells. Exosomes are a third of the price. They travel through tissue better. They cross the blood-brain barrier because they're smaller than cells. And frankly, cells are sticky. They have a lot more receptors. So if you do them IV, they go to the heart first. You know this. The heart takes a big chunk, great for the heart. Then they go to the lungs. You know this. And then the lungs take a chunk. Then guess what? They go back to the heart next. So the heart gets another chunk. And by the time they're distributed through the body does not get as much. Exosomes are more fluid. They go throughout the body. They have fewer receptors. They're very neutral and naive. They go everywhere. So we love them. We also use them focally in different parts. You asked me about efficacy. I can only speak anecdotally, right? I can't make claims. So I do a lot of structural, about a third of my practice, maybe a little more structural. We do joints and spine applications. We're very precise. We do high quality MRIs. We look for inflammatory targets, osteoarthritis, bone on bone, loss of cartilage, all these things. It's the same process. And joint inflammation is one of the early signs of total body inflammation, right? I have
100%.
And we have incredible examples of showing cartilage regeneration. Now, remember, I can't guarantee it. I can't explain but we have done it.
Let me stop you here, because when you first said, when a patient comes to my Las Vegas office and I do IV of stem cells and a few days later those are gone, I was about to say what happens in Vegas stays in Vegas. But then you went into the exosomes. Yeah. So I
need to write that down. I think if it's not trademarked, that's a marketing claim for it.
It's a marketing claim for you. Right? You gambled and you lost, or maybe you won, right? But so what actually are exosomes and what is their relationship with stem cells? Because this is, an extraordinary area of research. It is very popular longevity intervention. And so, from what you're describing, it sounds like exosomes are actually produced by stem cells. So give us an idea what exosomes are, where they come from, and what lives inside them.
So listen, everyone, all cells produce signaling to their neighbors. Cells talk to their neighbors. And some of those are distant, like cells that make hormones are communicating with distant organs. Again, the signaling is through external production of protein/peptides. Peptides are small proteins. And vesicles. Vesicles are taken in more readily by cells. They don't require a receptor, right? They just kind of, and exocytosis, they outbubble membrane encapsulated contents, and another cell takes that in by endocytosis, right? Remember that from...
So basically endocytosis, let me just translate this a little bit. Cells are capable of sending parts of themselves, right? That's what those vesicles are, right? They are able to kind of package a small part of itself and deliver it to the recipient, almost like mail, right? And this process is fairly passive because you don't need, some specific sort of lock and key mechanism, which is what typically molecules and receptors are. Like LDL has to bind to the receptor to be cleared from the circulation. So this isn't lock and key. This is more like mail being dropped off in your mailbox, right? That little piece of mail now is coming into the mailbox. You get it in because you're the recipient and you see what they wrote in your letters. So that's sort of the simplification of the process. So inside those vesicles, right, those exosomes, we call them exosomes. That's just a scientific name for that. Inside those exosomes are various signaling molecules, right?
Correct.
Okay. And so how, where are you getting those exosomes from, right? Do we produce exosomes internally? Like, does each and every one of us produces exosomes every single day?
All of our cells make exosomes. In fact, there are companies looking at cancer cells that release exosomes and using those exosomes as a very sensitive diagnostic. So when we use the word exosomes sort of loosely, we're really in a therapeutic sense. We're talking about stem cell derived exosomes that's sourced from amniotic fluid, filtered, tested, concentrated, fresh, frozen, unmanipulated, straight from nature.
Wow.
Amniotic fluid. But there are exosomes in other parts of our lives. Body fluids secrete them. Mother's milk, colostrum, bone broth, bone marrow, and plants deliver their phytonutrients through exosomes. Did you know?
I did not know that. All right. So you get those exosomes from stem cells, which are amniotic stem cells, perinatal stem cells. Correct. But I believe you also get them from plants, or is that not correct?
Yes. So when we talk about human injectable interventions, I told you I do a lot of joints and spine. We do intravenous wellness for inflammatory age issues, things like that. And they have another third of miscellaneous, aesthetic, hair regrowth, sexual function, other things. But we also have developed the first plant exosome nutraceutical, which is from the phytonutrients from plants, resveratrol, sulforaphane, quercetin, things like this are all the B vitamins except 12 and vitamin C are exosome from plants. So we have from curated organic Italian fruits, we have now a longevity single daily capsule that delivers at 700 times a liposomal supplement and 4,500 times a traditional supplement to the cell. It gets into the cell because it's encapsulated by nature's exosomes. So the cell gets a delivery. Because if I give you a bunch of resveratrol, it would bounce around. If you lose some of digestion, some bounces around in your bloodstream. That doesn't mean it's getting into the cell, right? So nature's already figured this out.
So how does this supplement survive passage through the stomach? Because, the pH of stomach is 2. So it burns, liquefies everything.
fantastic question. Now I know I'm not the only bio nerd in this conversation, but the plant exosome membrane is much hardier and will survive digestion, get into the small intestine where it's absorbed with high bioavailability. And this is well tested in preclinical studies, and we are just jumping into clinical. And this is something we launched about 10 months ago, and it's been just received very well. And we've had an increasing number of users. I use it. Everyone in my family and around the office and our, a couple thousand of subscribers have been using it. So it's available.
Nice. So, and we're going to drop a link to Dr. Jeff's supplement so that you guys too, listening here, could become the users. I'm very tempted to try it. So, but my brain is still thinking about the cells and cellular vesicles and exosomes. So back to exosomes, and we'll go back into the plants. Injecting of exosomes sounds like locally, right? As you're mentioning, structurally, does have an impact. So what kind of an impact are you seeing with these non-cosmetic sort of structural injections? And, what is happening?
We have wonderful examples of having someone who's nearly bone on bone and significant pain in knee. They've been told they need a knee replacement. And we've done a single injection, and within a year, they have some growth in the cartilage. So we turn back on that cartilage factory by turning off the inflammatory damage in the cells that produce cartilage, and allows the body to say, oh, I can turn back on the original factory that built this cartilage in the first place. And we actually have MRIs before and after showing 25%, and in some cases more, thickening of the cartilage, moving that person away from the need for surgery, reversing that. And this goes along with some European literature where they have 15-year follow-up in this approach. So we didn't invent this. Now we're trying to enhance how we target it based on the MRIs and things like that. But this is sort of the coolest thing that we do, is this cartilage regenerative injections.
That is amazing. And, in addition to cartilage, any other areas where you see this regenerative potential? And also, are you seeing, for example, at least logically thinking, once the inflammation subsides and people have less pain, they should, transition to lowering even systemic inflammation, right? And systemic immune system activation. Are you, and that's where for cardiovascular health, for brain health, this becomes so critical, right? So are you seeing any of those parameters shift, or is it a little bit too remote, from a local application?
No, when we do a systemic application, we've seen improvement in HRV, heart rate variability, which is a very sensitive metric. We've seen reduced inflammatory biomarkers like C-reactive protein, homocysteine, some lipid profiles. So we know at the cellular level we're influencing things. And then we have the clinical report. You do the IV, they have more energy, they sleep better, cognitively they feel sharper and faster, even though they didn't feel impaired to begin with. They notice a difference afterwards. So, we do a lot of that, knowing we hope to move the needle in the anti-inflammatory direction, which means the anti-aging direction.
And so you mentioned that in Europe, this is more of a prevalent practice, right? My understanding is that no.
I didn't mean to say that. What I meant to say is, in Europe, they've been doing this 20 years longer. And we know that because professional athletes would leave here 20 years ago and go to Europe to have a treatment. We now have those here. But a lot of the longer standing, really good studies with the long follow-up, the medical evidence, you and I hear that phrase misused all the time, that comes from Europe. So, or Asia. Asia they do a lot of things cutting edge. In China, they are really aggressive. So we learn from that. And because we want to see what's safer, we want to see what's effective. We want to apply, we don't want to just shoot from the hip, although sometimes we come up with a new idea and we might offer it to someone.
Right. So interesting. So what I'm going to do now is I'm processing this information because it's fascinating. Full disclosure, I don't do exosomes or stem cells because,
Not
I
yet.
still have to
Not
yet.
yet.
I had not yet. I have to come and visit Dr. Jeff and in Vegas,
Yeah.
so that I even understand what it is. But, there are some paradigms emerging right now that I think are going to potentially open sort of our mindsets to these additional interventions. Like, for example, with the proliferation of GLP-1s and GIPs and pretty soon triple incretins like retatrutide, we had seen significant impact on muscle mass and even bone mass.
Yeah.
There was just a recent study
Yeah.
just came out that, full pharmacological doses, people are losing muscle, people are losing bone. We do a lot of microdosing at holistic heart centers, so we actually don't see this. We see body recompositioning during the weight loss, but people using it in a more straightforward full pharmacological dose and scaling fast, they are seeing this. So I think that sort of will maybe shift the pendulum toward these more mitigating strategies, right? So what I'm trying to understand is, like, let's say we'll take a case of patients that are, very commonly in my practice, patients in their, let's say, mid-40s or mid-50s. Often they are busy professionals, executives, and whatnot. They're overweight, they're hypertensive. A lot of them already have coronary disease, whether subclinical or they actually had a first coronary event and they got stented. And so, we go obviously through all the usual culprits: lifestyle modification, fairly aggressive structured programs, weight loss, body recompositioning, anti-inflammatory protocols, hormones, sometimes peptides. Where's room for this particular individual, which actually describes a lot of patients, right? Where in that continuum of health optimization, longevity optimization, there is a point or the fork where you would say, this would something, exosomes may be of value here, right? So sort of what are these forks in the road, right? Because we're missing these forks in the road. A lot of the doctors are, because we sort of don't think about it. And, being in the longevity space itself, that there is a lot of value in diet and exercise and supplements and, kind of more traditional approaches. So take us through this.
Yeah, no, you're right. Listen, if we're going to do something in the regenerative or peptide space, we want to do the cheaper, easier things first. Maybe easier is not always the right word, but we want to fix the terrain. We want the right lifestyle, diet, exercise, nutrition, all the basics covered so the person gets the most out of it. So regenerative medicine is usually at the end fork, right? You do all these things first, then maybe we add some peptides, like you said, retatrutide, which I've been on for quite a while and love it. We have a lot of clients using retatrutide, the triple agonist, low dose for longevity purposes. We're seeing anti-inflammatory benefits in the long run, things like that. Mm-hmm. Whether you call it microdosing or just low dosing, whatever, it's very.
I'm an terzepatide user, so I love that medication, and I'm microdose to start. So we have to have a whole episode just on that. But okay, so go on. We can do it.
But peptides are an easier intervention before you go to regenerative medicine. Peptides are really part of that cell signaling and regenerative biologics, but peptides are less expensive. They're easy. It's a simple subcutaneous injection. People don't fret that. Diabetics do it all the time. And unless you're dealing with a focal issue like a knee problem, a hip problem, a spine problem, we would probably put anything systemic at the end of that, unless there was some type of early entry into the fork, the pathway. Maybe you have an autoimmune or a hyperinflamed situation. Maybe you have long COVID or some residual of a Lyme's disease or something where your body is just so inflamed and we really need to sort of pour some water on that smoldering fire. Then we might jump in a little earlier with an IV or something.
Interesting. So because what I often encounter is that, one of the issues that I'm seeing, and it's actually very common, is that we are systemically underestimating person's health risks, right? In cardiology, we have all of these equations. They're population-based equations. I actually have a platform called Heartwell.ai where we bring those equations, but we bring in genetics, we bring in imaging, we bring in all other parameters to really try to figure out what actually is the risk for this person, not, the population of individuals who may or may not be similar to them, but this person in front of us. And so what I'm seeing with this, and that sort of opened my eyes to what I always suspected, but now I'm seeing the numbers, is that we are systemically underestimating disease risk. And, with heart disease, vascular disease being so prominent, over decades, it hadn't really lost its perch as a number one killer of men or women. It's sort of worldwide phenomena now. We are really stuck because we have these fantastic interventions, like you had your surgery, right? We have our stents and pacemakers and defibrillators and a lot of other fancy gadgets, but that's sort of end stage disease management. Right. So the question that I sort of have in the back of my mind is that at what point, this more regenerative focus needs to come into play. If I have somebody, for example, who has high genetic risk. And, this study just came out. It was actually the initial study that 2 more studies will come out from a group at Harvard where they looked at patients with low cardiovascular risk scores, but high polygenic risk scores. They have a cohort that they follow. And they invited these patients voluntarily to come and have a CT angiography, right, with AI quantitation. And so basically what they discovered is that these patients had a calcium score of 0. So we're talking about soft plaques here. And so 50% of those individuals, and it was over 1,000 people who were young in their 50s and scoring low by traditional cardiology scores, had soft plaque. And approximately a third of the group actually had high risk features in that soft plaque. So where do we then start? Do you think that we as longevity doctors, is longevity missing this opportunity to start early? So at what juncture should this happen?
Early and often. The earlier you start and the more you do, if you're at risk, your AI has determined, these are risk factors for risky soft plaque. Maybe those people are on nattokinase, lumbrokinase, endocalyx, and you track them and we learn from that, right? We learn more and more. Mm-hmm. Is that a preventative intervention? Does that delay and stop what you're trying to do? Yes, we have to. I agree with you. We need to move earlier upstream in the pattern recognition, and you're doing that wonderfully with cardiac, and we need to do it for the whole body in all problems. And you're right, people are at risk factors. There are environmental and genetic, and of course, and then probably some complex interrelation of those two.
Very, very complex, because one of the most recent cardiology scores that gets criticized quite often because it tends to kind of give the lowest numbers versus other scores actually has at least one relationship to environment that has a social deprivation index based on your zip code. But we have articles, on microplastics. We just had a slew of articles in the literature on impact of fine air pollution, right? And so, one day impact already translates into increased cardiac mortality. So this is sort of mind-blowing. So give us an example, maybe what would be a typical patient in your practice who may consider getting systemic exosomes infusions. And I want to go back to exosomes so that you specifically define them a little bit more and explain the differences. What are the plant-based exosomes? What's inside of them? Are they sort of completely constructed by men, or are they, at least in part derived from plants, or always derived from plants?
Let me handle this.
So handle this.
So I think I have 3 avatars, 3 different types of patients, generally speaking. If I could cluster them, in data science, we talk about clusters of data. That doesn't mean it's necessarily segregated like those cardiac
data lakes.
Scores.
We're doing data lakes.
Yeah, because a lot of those scores that people come up with to oversimplify things are taking a complex non-parametric math problem and trying to apply a linear parametric solution, and that doesn't work. That's why AI fixes that, right? AI knows how to weight the different factors better. But the three type of patients are, we have sort of an elderly population that wants to keep their energy going, slow the inflammatory process, and they just do it periodically. Maybe they have lots of aches and pains, osteoarthritis and all the joints, things like that. Maybe, cardiac, dysfunction, cognitive dysfunction. We also use the Exosomes nasal spray to deliver to the brain. Turns out nasal spray is a wonderful way to get them to the brain. So we have some patients with Parkinson's and Alzheimer's who come in. We do a nasal spray every few months. Then we have the middle group of patients, say middle age. They're either becoming aware of their lack of longevity and their behavioral problems over the past decade, or they
it's catching up with them as I tell them.
Or they're, the wife sends someone in for a dad bod makeover, things like that. We see a lot of that. Maybe they're starting to feel lack of energy and aches and pains. And some of that requires some hormone optimization, a few other things to get that dialed in. And then we have the young biohacker high performance crowd, right? I want to slow the aging process. I want to I want to play better pickleball. I want to recover faster from my workouts. I want to be able to work at the highest level, So those are my three, where they come in for intravenous or systemic, perinatal exosomes. The plant-based is for everybody. Those are not man-made. They are from a lab in Italy that we found that can actually extract the exosomes directly from the plants, from the organic plants. Wow. So this is, why haven't we done this before? Because it was very difficult to do that. And it's still complex at the lab level. And we've known about extracellular vesicles for decades, but, true therapeutic exosomes have only been, in front of our face for about 9 years. So we're at the cutting edge of that, right? Cell signaling, efficient, hopefully cost-effective cell signaling.
That's amazing. And I think, 2 points that come across loud and clear is that number one is what is sort of the foundational approach to integrative functional longevity medicine is optimization of the terrain, right? The lifestyle factors still continue to dominate overall health trajectory. And so many of them are under individuals' control. What I find quite often, people are sort of searching for these magic bullets or whatever, silver bullet solutions, but most of these solutions are there. But then once you figured out or dialed in the lifestyle factors, there is this opportunity, I think, for optimization. A lot of it is regenerative. So would you say, for individuals who are not, trying to be like Brian Johnson and optimize everything continuously, but they're just, let's say, normal humans, and maybe they're middle-aged and they have a couple of risk factors and they have lifestyle dial in, or they, started some of those earlier therapies and lifestyle modification, how often would they need to get the intravenous exosomes? And what are you following as a parameter to ascertain, if they're working, right? What kind of blood work are you following? What kind of biometrics you're following? Like, how do you know that it's actually playing a role?
We follow first subjective. How do you feel? What's different? We usually, go through a health history, of course, and examine the patient first. And we know all their little issues. And then we can ask about each one of those after a treatment. And there's nothing more powerful than feeling better and being more functional, right? We follow HRV. I love for patients to have health metric monitoring, whether it's something on your wrist or a finger or something. So, and I'm wearing both.
You're wearing Aura and what else? I'm not wearing my Apple Watch today.
I'm trying out a new brand of ring, and then I have I wear two watches because I like two watches and have my Apple Watch. So yeah, Bionerd and Watch Nerd. So we watch HRV is a big one. We could do VO2 max and grip strength and a bunch of other things. We don't do that routinely. In terms of lab markers, we look at inflammatory panels, C-reactive protein, like I said, homocysteine, lipids, omega-3s. Of course, we dial all these people in with, the right supplementation. And usually C-reactive protein is my go-to. We've seen improvements in those panels. We're starting to look at metabolomics and, because there's a complex interaction with the gut microbiome and things.
Sure.
And we're looking to see if there's a difference before and after with the metabolomics, which might tell us more about exactly what's happening. We know with the plant exosomes, which is separate, that there is reduction in reactive oxygen species, increase in sirtuin-1 gene, anti-aging gene activity, a few other improved cell aging markers. So we know that's a longevity supplement. We also see similar things when we do the IV human, perinatal amniotic exosomes. So a young person, a biohacker, might do it every 6 to 12 months, depending on their appetite for it and their needs and their desires. A middle-aged person like myself, I do it every 3 months. That's about when I start to feel I could use a little kick. And everyone, it could be different. Of course, I have easy access to it, right? My nurse can just hook me up while I'm doing a podcast, which we've done. Now, the elder population, we do it out as needed. So I have one lady has diffuse osteoarthritis, can't do her crafting, and then she gets an IV, and then she can do all these things again. She's independent. She can drive. She's 82 now. She does it about once every year. My mother flies in once every 6 months. That's just the recipe that works for her. So we customize it. We ask you, how do you feel? How long did it last? And we let people be part of that conversation. So we don't have a one recipe fits all.
Right. So, but it does make sense because, you kind of adjust it to the burden that your patient is experiencing, right? You don't want the treatment itself to become a burden. So you mentioned HRV, and HRV is such a powerful metric, but affected by so many different things. What do you typically see percent-wise as an improvement in HRV? And do you see it sort of sustain itself for a certain period of time until the next injection, or is it sort of like lasts for a few weeks? Where does it fall?
There's typically a boost. I've seen up to 50% increase in a few days after an IV, which is amazing, right? So I have a very high performance athlete, and he's a young man. He's in his 30s, exercises, works out, plays pickleball, all this. And he did an IV, and we talked soon after. He goes, I really didn't feel a whole lot. But then the next day he sent me a screenshot of his HRV before and after, and he went from the 60s up to the 90s. So that's your 50% boost. Now, not everyone gets 50%, and then he had a very slow decay over months. Okay. So now some people might have a faster decay. Depends on how much inflammatory burden you have. Right. So everyone's different, but it's really worth tracking.
Yeah. I agree with you entirely. And I think, we can spend a day or two or three talking about the role of inflammation and inflammaging and, how it literally, among those 12 hallmarks of aging, inflammation is one of them. But honestly, it should sort of be attached to every single other hallmark on the list, 100%. And, we are fortunate in that laboratory wise, we have markers available there. Most of them are available through regular commercial labs. And that even includes vascular specific inflammation markers. So, so we are fortunate with that. So if anyone is listening to us and you don't know what your high sensitivity C-reactive protein is, or you hadn't checked it in a while, or you never checked your IL-6, please do it at your next blood draw, because that would be super impactful. And of course, there are genetic predispositions that I think, unfortunately, position some patients in a less favorable way, right? They are more pro-inflammatory, if you will. So fascinating discussion, Jeff. Tell me, what is Recelebrate? Is that the name of the supplement line? Because it's on the screen. I just want to know.
Well, we renamed our practice a number of years ago to focus on what we're doing now. So we're celebrating the renewal of your cells, and that's the Recelebrate. So now we spun off the Recelebrate nutraceuticals, which has our longevity exosome product that we call Longev X.
Okay.
So you can find that. We'll get you the link, and then you can share it if people want to look into it. And then you can replace a lot of simple vitamins and phytonutrients you may be already taking with one single daily capsule, and you'll get much more out of this. And so that's sort of our existence right now. I'm doing so many more things I ever thought I would do as a doctor, and I'm having a renewal of my own fun, and I'm re-energized and more passionate now than ever. And I wish I had these tools for all the decades of my practice.
Well, but you know what? I think like that too often, right? I wish I started to do what I'm doing now earlier, because I'm having so much fun, not just for myself, but for my patients. You know, the other day, this young patient, I think he fits with some of your patients, and I'll probably send him your way because he's young and he's an exerciser, but he had some joint issues. He actually had a hip replacement. He's an executive, you know, very high LDL, ApoB, unfavorable genetics. And we worked with him without medications. We're able to drop his LDL cholesterol 47%. And, you know, I didn't know it happened because I didn't have follow-up labs. He sent me a note from his executive physical. And the note from the executive physical was from Cleveland Clinic. And I thought to myself, oh, you know, they're going to blast all over it and they're going to say, put him on a statin. And so I opened this note, and the whoever was the doctor there, the executive physical, actually listed every single LDL and ApoB number, showed the progression, the drop, and ended this table with saying, continue working with your functional medicine cardiologist. I said, that's it. This is woohoo. This is where it lands, because you know, maybe right now mindset is more open, right, for patients and even for more conventional physicians. Now we have the tools. We have these wonderful exosomes that you're developing. We have the knowledge. We have the skill set. We have AI that could help us, you know, to sort of figure out, you know, create a digital version of you, which is what we do. We have these digital twins, you know, so there's a lot of opportunity. And I think, you know, patients actually could access it, because before it was sort of mostly investigational. So I think, you know, this has been a great conversation, Jeff. And, you know, for all of our listeners, we'll drop all the links to Dr. Jeff's plant-based supplements so that, you know, I'm anxious to try it. And I know what I'm going to do next time I'll come to Vegas. I think I'm going to get, you know, that little IV for myself, you know.
You're always welcome here. By the way, most of our patients are not living in Las Vegas.
Right.
I just happen to live here, but we can talk to anyone, anywhere, remotely. And then if you are a candidate for something, we'll invite you here. Luckily, there are lots of flights in and out of Las Vegas.
That's right.
So come visit us, see a show, have a nice dinner, you know,
get IV of the exosomes.
Exactly.
You know, it's great. Okay, Jeff, it was nice to have you.
You too. Thank you so much. Be well.
You're welcome. You're welcome. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Heart Centers. If you enjoy the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticheartcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.